much for conducting this hearing, and appreciate our witnesses. Thank you for what you do in your communities to make certain that citizens, patients are well cared for. Let me start with the Kansan. Mr. Stover, welcome to our nation's capital. Thank you for coming from Kansas to testify. I want to go back to what I was trying to raise with the previous panel about actual cost-based reimbursement. Can you give us an idea of, even though presumably you receive 101% of costs, what percentage of your actual costs are covered by that reimbursement? You might start by telling us what percentage of your patients are Medicare and Medicaid, what's your payer mix, is there public or taxpayer support for your hospital? How do you make this work, even though presumably the image is that you're getting 101% of your costs?
Thank you, Senator Moran. Within Hospital District Number 1 of Rice County, our Medicare volume is about 63%, Medicaid volume of about 10%. We are a taxing entity. We are able to appropriate tax funds from our district, which is about $900,000. What's interesting with that number, in our fiscal year ending in 2014, we ended up having to write off nearly $800,000 to Medicare bad debt. So that essentially washes itself out. When it comes to the cost base, you're absolutely right. Our reimbursement of 101% does not equate to our total cost of providing that health care within our facility. I would, not knowing that number off the top of my head exactly, but I would say it's probably around the 75 to 80% margin, which covers our cost. So we have to look towards our local tax base to make up that difference, or otherwise start looking at reduction of services, which we do not want to do.
It used to be that hospitals would tell me that that mix, that 70-some% Medicare, Medicaid, I suppose you do everything you can to cost shift that to those who have private insurance. But are those opportunities available now? Is it better to have a Medicare patient, a private pay patient, a Medicaid patient as far as revenue? How do you compensate for less than actual reimbursement of costs? Where do you make up that money other than taxes? Can you do it with private pay?
We work towards our uninsured, our private pay in their struggles. But no, it doesn't come towards.
Let me ask the question this way, Mr. Stover. Are you pleased when a Blue Cross and Blue Shield covered patient walks in your door? Does that mean, oh, this is a better deal than if it was Medicare or Medicaid?
We look forward to the Blue Cross Blue Shield patient coming to our facility.
And the problem is the percentage of those who come in the door is a small percentage.
A very small percentage. Yes, sir.
You mentioned uninsured and having to write off costs, and I'm not trying to portray this in any partisan or the way this issue is looked around here too often, but under the Affordable Care Act, a theory was that there would be more people insured. Has that proven to be true in light of what you just said about hoping that the private insurance covered patient walks in the door?
We have seen a small increase of those individuals that were once uninsured. We're finding them to be enrolled in Medicaid. In our state-based MCO program that we have seen a small increase in the marketplace of those that once did not have insurance, but otherwise found it on the marketplace. But when you look at the overall, that is a very small percentage of those individuals. They still find themselves uninsured.
Some hospital administrators have told me that even with additional insureds, that the co-payments and deductibles are higher, and therefore the bad debt expense has increased even with those who have insurance. It used to, I think the way I describe this is somebody who had a $100 co-payment could come up with $100, but if it's a $5,000 co-payment, they can't do that, and so you end up writing off more, even though there might, as you say, be a slight increase in insured?
That is correct. We're finding that even though that the copays in the past have been lower, we're finding that the copays now, those individuals are now on a payment plan, and in turn, sometimes we're having to write those off. Yes, sir.
Let me ask a broader question. Perhaps it's Dr. Henderson, but although Ms. Peterson talked about telemedicine as well, I just like to have the summary of the costs associated with telemedicine and how they're paid for. And as I was listening to your testimony, I jotted down three things I think that a hospital would have to pay for: the equipment. And I'm interested if you could just, I'm sure you've told this in your testimony, but I'd like to get this in a short summary so that I can understand it. You got to figure out how to pay for the equipment. You got to figure out how to connect and how that's paid for. And then finally, how does the provider get reimbursed for providing the service? And my question there is, when the University of Kansas Medical Center in Kansas City provides telehealth to the Rice County District No. 1 hospital, is there a reimbursement to the physician who is present in Kansas City at the major hospital? And is there any reimbursement that then comes to the hospital that's providing the service at the other end? I don't know who's the person to answer that question, but.
Yeah, so your points are absolutely correct. There has to be a purchase of equipment, there has to be connectivity, and you need to pay for the medical or clinical services that are delivered. So that's accurate. How we're doing it in our state is that our Center for Telehealth is providing all the equipment. So thanks to some of these federal funding dollars, I'm able to deploy that. And so that is not an upfront capital cost to them.
Would that be, I know you're talking about Mississippi, but would that be true generally, you think, across the country, that there are grants available for the equipment?
The majority of all of these programs have started off of grant money.
Thank you.
And then in our state, we're able to pay the provider that delivers the services. So the telehealth physician or nurse practitioner, whoever, is paid through their professional fee through reimbursement. And
here you're talking about the provider out in the rural setting.
I'm talking about the provider, the other side.
All right.
So where the patient is, there can be a facility fee billed, and that can be reimbursed as well. And that helps to offset their cost for facilitating that interaction. Typically, it's not a provider to provider because both providers cannot be paid for the same service. If you have a generalist with a specialist and they both do an exam, then they both can bill.
So you have a general practice physician at Rice County Hospital District No. 1 and a specialist at the KU Medical Center. Both of them can bill?
If they're doing different services, yes.
And so there is no disincentive to a provider to make this happen?
As long as you're in a state that allows for parity reimbursement.
All right, I'll have to figure that out. And then finally, let me ask you to clarify for me, when we talk about that reimbursement, does it matter who the payor, who is providing the insurance, Medicaid versus Medicare versus private insurance? Is your answer the same in all three settings?
It's not, and it depends on your state and what the legislation allows for. And then Medicare has geographic restrictions as well that we've heard. So, but in our state, all public and private payers in Mississippi, Medicaid included, have a parity reimbursement for telehealth, same as in person.
Chairman Blunt, do you want me to stop or ask one more? So Mr. Stover or Missouri, maybe this will make Senator Blunt happy, Mr. Walters, how does it work in Missouri as far as Medicare versus Medicaid versus private pay for telehealth? Or Mr. Stover, how does it work in our state?
I can answer that. In Missouri, we've invested heavily in telehealth in Bolivar, using grant funds for the equipment. The problem with Medicare, the geographic restrictions are such that we have a network of 12 rural health clinics that we operate. They are rural for the purpose of being rural health clinics under the Medicare program. 4 of those clinics are considered urban for telehealth purposes. So if the patient is in that rural health clinic, in an urban rural health clinic, then they are not covered by Medicare and cannot access telehealth services. We also have 6 long-term care facilities that we operate 2 of those 6 are in urban locations. So there are times when the patient may have an event going on at the long-term care facility. We'd like to have a doctor see that patient, but if it's at an urban facility, then they cannot use telehealth under the Medicare program. So we essentially would have to transport the patient by ambulance over to the ER to access care that probably could have been provided by telehealth, except for the fact that Medicare defines that as an urban facility.
From a reimbursement of cost to the Medicare Trust Fund, that doesn't make any sense, right?
No, no, sir. No, sir.
Chairman, thank you. I think
You used all of your time and all of my time. It was
of
astounding.
Missouri and Kansas cooperating.
Exactly. Ms. Stover, you mentioned